Just because otherwise it gets a bit boring on me own. If you were here last week, great if you managed to make it this week. Those who weren't there last week, my name's Mandy. I'm the Senior Pharmacy Technician for HealthWest PCN, and I'm also the Prescription Hub Manager. So I work all day on repeat prescriptions. So I do understand your challenges and just how busy it is, especially after this bank holiday. So obviously level 1 was sort of like basic. This time we'll look into more into how we do reviews and why, and also what the patient can get out of medication reviews. Understanding the whole repeat prescription process, different things that can happen. Again, we'll go through some generics and brands in a little bit more in depth. And I don't know what it's like in your practices, but I do get a lot of requests back from the dispenser applying companies where we've ordered a prescription, it's either been the wrong quantity or the wrong appliance. So we're going to do a little bit around stoma patients and how you can help those patients who sometimes get caught in the middle of the hospital and the GP, and if they can't get a hospital appointment, the GPs really don't know that much about stoma appliances, and they sort of get left to their own devices and then start surfing the internet for trying to find ways around it. So hopefully that'll be some use to some of you, because I can give you some contact details for the stoma teams as well. And again, this is all about you being knowledgeable and being confident in what you're doing, which will help the patients. Right, just a little quiz there. You can all see the screens all right, can't you? You can all see the slides. If you just want to take a couple of minutes and work your way around there, you can put any of your answers in the chat box. I'll go make myself a cup of tea while you're doing that. If you can't add if you haven't got all the answers, just put in the chat box the ones you've got and just go through the others. It's only just a bit of fun. Just to give you a clue, the insulin question gets everybody. Yeah, Manchester was definitely the first NHS hospital. I always assumed it was London, to be honest. Question 2, can anybody practice herbal medicine without a license? Yeah, it doesn't need anything. It's classed as a food, not a medication. So anybody can sell herbal medication, and there's no laws or anything around it, no standards. Number 3, this honestly, this question gets everybody. An insulin pen can be kept at room temperature for a month. After a month, then it's no good, but they should, patients using insulin should keep one pen out of at room temperature at all times. It's not very pleasant putting cold insulin into your system. So that should be out of the fridge at all time, and the ones you're not using should be in the fridge. As soon as that month is up, usually it's only enough to last them a month anyway, they should get a new pen, but no, it will last full 30 days. So number 4, are you all familiar with Formio? Have you all come across it and what it actually does? We'll do a little couple of slides on Formio and what's allowed on there. It's just the dressings. Care homes can use it, and of course, doctor surgeries can use it for their treatment rooms as well. But the care homes have got different formulas usually from the assistant, ones that are sort of nursing homes or residential homes. They are slightly different. Yeah, most of you got aspirin right for the 5th one. And we should all get number 6 right after last week's level 1. Yeah, it is 30 days, 28 or 30 days. If the doctor wants the patient to have it for longer than that, it's not a problem. They just need to document it in the records why they're giving more than 1 month's supply of a controlled drug. Okay, so a medication review. Really, if you're the pharmacist or the doctor or a nurse doing this review, it's all about having an agreement with the patient and optimizing that medication and making sure it's working for them. And we all know patients who just don't take their medication. They don't know what they're taking it for. They have other problems with it. So this is one time that the patient, they can actually speak. They have time to go through their medication with the pharmacist or the doctor or the nurse. And then they can ask all the questions. It's not very often patients get much time to do this. So if you can just put in the chat box, when you book a medication review for a patient, how long do they usually get? I know usually a doctor's appointment is like a 10-minute one, but I know our pharmacists, if they've got a complex patient, will try and give the patient 15, 20 minutes at least with a medication review. especially if you've got a complex patient and needs to go through a lot. So yeah, so 20 minutes for the pharmacist, yeah, 20, 30 minutes it's about right, really. If you're going to give that patient a chance to go through everything and ask all the questions, you do need to give them some time. And it also gives them time to ask about over-the-counter medication they're taking as well, because that might also impact on the medication they're being prescribed if nobody knows. Especially things like St John's wort, that interacts with people taking antidepressants. So it's always good for the patient to bring everything they're taking. So we've got doctors, pharmacists and nurses who can do medication reviews. Nurses obviously do a lot of pill checks, they do a lot of asthma reviews. And I don't know about over here, but in Wales, we have a lot of paramedics who are working in GP surgeries now, and they can also do reviews. So pharmacists for medication reviews are probably your best. So if you've got a patient struggling with their medication, it's always best if you can book them on with the pharmacist. Have you all got pharmacists within your practice or within your PCN? I forget, we are quite lucky in HealthWest and we've got quite a few pharmacists. Yeah. So if you can book them in, they're definitely the pharmacists are the ones to book them in with. Right, so the benefits of a medication review, it checks the patient if the patient's actually taking them and are able to take them. You know, as they get older, their swallow gets a bit more difficult, so it gives that patient a chance to talk about all those things. Like I said, over-the-counter medication, if you ask the patient to bring those in with them as well, so the GP or the pharmacist can have a look as well. It does reduce medication waste because the patient will then know what they're taking it for and are more likely to take them. Excuse me. Enables patients to ask questions. You know, when my partner has a medication review, I always say to him, write down the questions because you always forget when you get there. And it reduces the likelihood of any medication related problems or, you know, patients having side effects and just not taking them because of those. So it's always worth, like I said, it's always worth getting those patients in for a review. And the thing is, you know, we check non-compliance because non-compliance is a huge problem. And we never know until we sit down and speak to the patient why that medication is not being taken. And like I said, it could be swallowing difficulties, it could be their memories going, just could be something simple like they've got arthritis and they can't open the bottles. Well, then we need to talk to the pharmacy and try and work out another way of them getting the medication. Lack of understanding, if they've got a lot of medication, patients do get a bit worried and they're not quite sure. They've come in out of hospital. When I was a hospital technician, we used to have time to sit and talk to patients and go through their medication with them and tell them exactly what everything was for and what had changed. I think the last few years I was there, it was literally run on with the TTH, run back off. You never even spoke to the patient. So a lot of patients are coming out of hospital with no idea what's gone on and what's changed. And no improvement of conditions. They're taking medication and they're just thinking, well, why? Nothing seems to be getting any better. And like I said, then all of this ends up as stockpiling medication because now they've got this pile sat in the corner they don't want to take because they've forgotten what they were taking it for anyway. So it is good if we can, you know, when you see a request come through and you can see a patient's not ordering all their medication and maybe they haven't ordered medication since last year. Look in the records and see, well, it's not actually been stopped. Why are they not taking it? And then I will usually contact the patients and say, look, do you want to have a medication review with the pharmacist just to go through everything? And they're usually really grateful and quite happy to be able to sit and chat to somebody without being rushed through an appointment. So they're quite easy to spot, the patients that need a review. And again, like I said, this is when we do get to spot that patients are struggling a bit with their medication. and like I said, you can see that they're only ordering half their medication and they're over ordering some, they're not ordering other medication. And like I said, this is the time then to see, do they need a Dossett box? How are you all coping at the moment with the Dossett boxes? I know a lot of pharmacies around by us are not doing them anymore, or haven't got capacity anymore. So are all the pharmacies run by you still providing Dossett boxes, or are patients being left to their own sort of devices? No, it's a shame because they can work. For certain patients, they do definitely work. They don't work for everybody, but so there's many different ones. These here are sort of like the self-filled ones that you buy in the pharmacy. Yeah, you definitely need that, but you definitely need a Dossett box team. You can't, it's impossible to keep switching back and forth. These sort of things you can buy, and families do self-fill for patients. But the problem with this is if they ever have to go into hospital, there's no information of what that medication is. It's just a box with a pile of tablets in, especially if they're all white and nobody can see what they are. And then, like I said, these are the official Dossett boxes with all the times, dates, descriptions, and what the medication is for. And if you've got a patient with lots of medication, they do work, they can help. Like I said, they're not the answer to everything, but they can help patients not get so overwhelmed by all the medication in boxes. And like I said, they can assist. They do help patients if they're confused, and they do give them a little bit more confidence to take them. And they, hopefully then if you can optimize the medication, so you've got to take it once or twice a day, again, that helps. If you've got a patient with memory problems, the only way it's going to work is if a family member is there to help them a couple of times a day to make sure that they're taking that medication out of the Dossett box and taking it. Like I said, there are ones that put alarms on it, so the alarm will go off. But if a patient's got poor memory, they're not going to remember what the alarm is for. So I don't know, a couple of people have tried them and they've not really got very far with them. So I think you do still need the family members and carers involved to help them. But like any system, there's some disadvantages. You don't always get patient information leaflets with them. There are limited spaces if you've got class 2 and, cocotamol or something really big, but you only got a limited space. Lots of medication like Epilin Chrono, soluble aspirin won't do very well out of packaging, and they swell because of the air and the dampness in the air. So they're no good either. They're very time consuming for pharmacies. That's why a lot of the pharmacies are dropping them. There is a higher risk of error because obviously you're putting it into a box. That person who's checking it has really got to know those boxes quite well. That's why it's better to have a team. And they're very expensive for the pharmacies and not at all cost effective. When I was doing them, one of those Nomad trays there was £30. Each patient will have 3 because it's a weekly one. You've got the one the patient's got, the one ready to go out, and then the next one to fill. So you're talking £90, and that was probably about 20 years ago, to have 3 Dossett boxes for one patient. So it is very expensive. And that's why the pharmacies like their weekly scripts, because it does offset some of the cost. All right, so monitor doses. Like I said, so how are you managing now when patients are getting left with no Dossett box and you left trying to find the new pharmacy? Because I know that's what happens with us, is they're like, where do I go? We have got a list now of pharmacies who will do Dossett boxes, but a lot of them is in one out, one in rotation at the moment, so it is quite difficult. And then you end up we've got some patients now over the other side of Bristol getting their Dossett boxes, so that just makes it a little bit more difficult as well. But hopefully things will settle down. Handwritten prescriptions. We probably don't see many now, but they are still done, especially when doctors go out on home visits and things. And also, if there's a medication which is not on EMIS, and it happened with the Dexcom one when they came out, they weren't on the system. They were in the BNF, but they weren't in the system, and we had some stoma appliances as well. So there are a time when you will need to do a handwritten prescription. The problem then comes, how do you code that prescription, and how do you know it's been actually issued? Because we're so used to that electronic system now. If something sneaks past us that's not electronic, it's like, oh. So like I said, there's a few instances when you would do that. Who's responsible in your practices for either putting that onto the system or coding it, or letting everybody else know that that prescription had been done if it's not been electronically done? It's just scanned on, like if you like, a clinic letter, or is it up to the GP just to write in what they've actually done? So or do you just leave it up to your pharmacy team to have a look at and see what's going on? So we do have a few specials that we have written here that are handwritten just because they're not on EMIS. So, like I said, is it recorded on your PMR, or is it just coded as a handwritten prescription and nobody really knows until they sort of dig about and find it? It would be interesting to find out if, you know, that might be one thing to look at, and just say to your practice, what would happen if, say, your GP is in a care home, the Wi-Fi's gone down, and he's had to write handwritten prescriptions for the care home. How would that then go onto the patient's record? But we always talk about all the different things we have on repeat prescription. And like I said, we do prescribe an awful lot, but there are lots of things that we shouldn't really put on repeat. Can any of you think of anything that you shouldn't have on your repeat system? Should only be an acute medication? You just, yeah, so just type it into the chat box if you like. I don't know about you, but what I have in my head of what we should have on repeat and what is on repeat is a different idea sometimes, depending what GP it is. Yeah, antibiotics, unless it's a rescue pack, yeah, or for a sort of like long-standing UTI problem, yeah, definitely not antibiotics. Sleeping tablets are something else that really shouldn't be on repeat. Really, sleeping tablets should be for the short term, maybe for 7 days until you get yourself back into a sleeping habit, but it shouldn't really be any longer than 7 days. Yeah, so that's that said. Smoking cessation therapy is another one, really, that should be done and dusted in a short time. Yeah, methadone, you'd hope. I've seen quite a few addicts been on methadone for years and years. There you go. So smoking cessation should, again, because that's supposedly a short-term thing where they reduce their nicotine levels down, and they should need it to be on repeat. Thrush treatments, head lice, weight loss medication, because again, that should be a short-term thing, and cough treatments. I don't think we actually give much out for the way of coughs now like we used to, but I do still see a few. Yeah, they're the main things that you shouldn't have, especially head lice treatment and thrush treatment. They definitely shouldn't be on repeat. So a little bit of a question for you all. So, got an acute item, patient's only had it for a month, and they've just rung you up and said, oh, you know, I got this, it's on acute, I can't see it on my app. What are the rules in your practice about how long a medication should be on acute. So say the patient's just been put on bisoprolol 5 milligrams twice a day. That came from the hospital. It was please try this for the patient for a couple of months, see how they get on. Have you got a set? Oh, it's on repeat it's on acute for so long, then we move it to repeat. Because it's very frustrating for patients when I look at some patients and they've had things like omeprazole on acute for 2 years. I just move them. But if it's a new medication, they've had it for 3 months and there's been no problems, I will then send the request through to the doctor. But I will say, like, patients had this for 3 months, they've got no issues, can you move to repeat? It just makes it easier for the patients when they're ordering via the app. And it also makes it easier if the pharmacies are ordering via that app as well, which some of them do, because you can't see it when it's on acute, even though it's there. Right, you task you, right, okay. Yeah, I'm trying to see if I can get some sort of, I don't know, thing across all of our 4 practices that if a patient's had an item on acute for 3 months and there's been no problems, that we automatically just put it on to repeat. If it's a repeatable item, there shouldn't be any reason, like I said, you know, to see something like omeprazole sat on acute for years, it's just frustrating for everyone. So that's one of my missions at the moment, to get everything off acute that's been there for 3 months or more. So I don't know if any of you have got that sort of policy in your practices, or is it sort of dependent on the GPs and dependent on the medication? You know, I know with a lot of the shared care stuff, some of it's come in, and HRT is all a little bit, there's always things to change. But yeah, if you can, it just makes, like I said, just makes life a bit easier for patients when they're trying to order their medication and it's stuck on acute for too long. But yeah, I always, like I said, 3 months or more, I start to nag the GP to see what they say. Right, bit of a question, yes. Repeat dispensing or batch repeat dispensing, how is it going in your area? Do you use a lot of batch repeats, or is it just for Dorset box patients? Or do you use it for patients who are stable on their medication, who are taking things like thyroxine and are up to date with their blood tests? Or do you just not use repeat dispensing batches much? Because this is you know, I know there's a big push now to get repeat dispensing back up and running. Yeah, it's, if the pharmacy doesn't explain to them, if we don't explain to them at our end in the beginning what a batch is and how it runs, and then the pharmacies don't follow up and say when the batch is finishing, this is where it goes wrong. And like I said, it should be an agreement with the patient and the pharmacy and the GP, so everybody should know about it. And then sometimes this is when it goes a little bit wrong as well. Things get put on batches, they don't really explain to the patients what they are and how it works. But there are benefits. My mum's been on batch repeats now in Wales for probably about 6 years. Touch wood, it works perfectly for her. But we haven't got an electronic system, so the pharmacy can see it. They've got the paper copies in their hands, and I think that does make a little bit of a difference. But they can reduce GP's workload. If it's managed properly, it is definitely more convenient to the patient. They just go to their pharmacy every couple of months and get it. It does reduce waste and the use of unneeded drugs, because behind these batches there is a set of health questions for the pharmacist to answer, to ask the patient when they come in. You know, are you taking this regularly? Is it working for you? Do you have any side effects? So there is that check. So they do, if you like, get a little bit of a mini meds review if it's done properly. And it's better use of the pharmacist's skills because he can go through that with the patient. But there are disadvantages, and most of this is around ordering. Patients can't see ERDs on the online app. So that causes a lot of problems for us. I'm doing a little bit of a mini audit at the moment just to see how many emails and phone calls we get every day asking for batches that are already there. You know, if the pharmacy doesn't tell the patient they've got their last batch and they need to order, this is when you get the urgent request then, because they didn't realise it's now Friday afternoon, you've got an hour to go, and they realise they got no medication. And another thing is if it's students, like part of our group is a student health service. So if they put a batch in Cardiff, in Bristol, and they move back home to Cardiff or London, they can't get their batch. Or if they go away working, they can't get their batch. They should be able to phone the pharmacy up and say, can you put my batch back on the spine? But it's whether they can actually get through to the pharmacy. And online pharmacies have come to realise do not know how they work. So at the moment, that's another bit of an issue. One of the patients rang me up the other day and he not long switched to an online pharmacy. So I'm going to have to go back. They've told me they're only set up to do one-off prescriptions, not batches. So that's another problem. If you've got an online pharmacy, it does become a little bit of a problem. And at the moment, and this is nobody's fault, there's nothing much we can do about it. Medication on batches out of stock. So you're in a way then doubling your workload because you can't do anything with that batch. You can't get that medication, and at the moment, I don't know if the medication out of stocks is going to get any better. The last couple of months, it seems to have got worse. So that's another thing that's causing us a bit of a problem. Does anybody else have any other issues with them, or is it all working out quite well for you? There is a handbook, and we're waiting for it to be updated. I would have shared it, but it's not the new one up yet. So keep an eye out, and there should be a new ERD handbook out, which will give you more ideas of how it should work and what medication should be put on there and how you identify the patients that can have the batch repeats. But so as soon as one comes out, I'd keep an eye out for it. It is quite good. Right, EPS tracker. Do you all use the EPS tracker? Because this is the way you can track your ERDs as well. So when the patient comes back to you and says, well, I've been to my pharmacy and they say they haven't got them, you can actually see on the tracker where you are with them, how many you've spent and how many they've got left. So the tracker I probably use all day. I check to see if the prescription's being downloaded by the pharmacy, if it's been dispensed and it's just waiting to collect, if it's been claimed, you know, and how many, like you say with the ERDs, how many are left, how many issues are left on there. And like I said, if the pharmacy has not downloaded it and they've told the patient they can't get that medication, so they've not downloaded their prescription, you just give them a code and they can just take that anywhere then. But it's linked to your smart card, so it's very easy to use, and it's quite handy as well if you've got a request for a patient and you don't know what pharmacy, what surgery they're registered with. Because like I said, we've got 4 separate surgeries, they're not merged. And we often get emails in and there's no surgery attached to it. So we just go on the tracker then, we can have a look and see what surgery they're registered with, save it waiting until somebody gets back to us. So when you look at the tracker, you will be able to see, look, that it's been uploaded successfully, it's been dispensed. So at that point, it should be sitting on the shelf waiting for the patient to go and collect. And again, with this one now, there's another one there. So it's to be dispensed. So it's with the dispenser. So they've downloaded it. As soon as it says with dispenser, that means it's gone to the nominated pharmacy and they've downloaded it. So like I said, you can track it then as it goes in. It's an acute prescription with dispenser. So that pharmacy has got it. Now this is your repeat dispensing ones. So the first batch they pulled down, it's with the dispenser, they pulled it off the spine and it's going to be dispensed. And it's telling you here, there's 2 of 3 and there's 3 of 3 to be there to be dispensed in the future. So if you ever get, any queries about your ERDs, check on your tracker and have a look how many the pharmacy have dispensed out of those batches. Because they are quite easy to spot. And it does say on EMIS as well, you can see 2 out of 3. You can see how many they've actually downloaded. But then that gives you more of an idea of, has the first one been dispensed? Has it been returned? So you can actually see where you are in that sort of queue. And again, this is just a repeat prescription. It's just 1 of 1. It's been dispensed. If it's got claimed, that means the pharmacy has dispensed it, given it to the patient and claimed the payment. So it's gone. There's, that's it. It's been claimed. It's filed away. So the patient's obviously collected it, and then they need a new one. Predated scripts. Do any of you use a lot of predated scripts, which are a little bit different to batches? Batches are a little bit more flexible in that if a patient's going away and the pharmacy has 3 batches and they need their 3rd batch early, the pharmacy can actually go and download it early. It's not a problem. They can take it early for holidays and things. Or if they're going into hospital, predated are a little bit different. This is for when medication is restricted and the doctor only wants them to have a weekly issue, or some cases a daily one. Pharmacies don't have access to them or can't see them until the day they're due. So if you've got a patient who has 2 diazepam every day for a week and a prescription is due on a Tuesday, the pharmacy won't have access until that day. So they can only collect it on the day it's dated. So there's no flexibility at all in the predated ones like there is with the batch ERDs. So when you look at EMIS with the predated ones, you will actually see when you go into the medication and click on it, you will actually see how many the dates that it's there. So that's the difference with the predated. Your end date will be the last date. I had one today and I thought, oh wait, there's sleeping tablets. He's actually got one for the 15th of next month. So you can see that it's issued in the future. So the tracker does give you a lot more information, and it gives you a chance then to check on your PMR and see what's out there. Like I said, it's like anything else. It's got the advantages. It's great. It assists with them with their managing their sleeping tablets and their diazepam especially. They don't have to request medication every week, so it's less stressful for them, and it reduces workload for the practice as well. Again, disadvantage, it's not obvious. When you first look at that PMR, it's not obviously their predated prescriptions. You've got to go in, you've got to look at the dates, you've got to check to see how many you've been issued, and also check on the tracker and see what's, where they are. Like I said, it's difficult for the pharmacies to manage their workload if all these daily or weekly prescriptions drop down all on the same day. And again, another issue, and I've talked about this with our pharmacists, so there's no answer to this one, unfortunately. Nobody knows. The only person who knows what the last one is when you go onto the system. The pharmacy won't know because they don't see it until the day. Unless the doctor tells the patient when the last one is being issued, or they phone us up and say, oh, how many predated scripts have I got? we find a lot of the time they run out. So has anybody got a system that they got? Because I'd love to, I need a system. I definitely do, because it's the one thing that we've got no way of tracking it until the patient runs out or goes to the pharmacy on that day and says, where's my prescription? And there's none there. So who manages these weekly batches, these weekly predated scripts? I don't know. I'm just wondering whether they should task us in the hub and say, can you order this when it's running out? But again, it's how do you manage? We've got quite a few people. I don't know how many patients you've got. We've got quite a lot of patients on predated scripts. And trying to keep track of them is really difficult. And because it's not a batch, it doesn't tell you on the tracker that it's 2 of 6 or 3 of 6. So like I said, if anybody's got a good system or user one, give me a shout. It's good to try something. So yeah, they are, like I said, very different to ERDs and quite difficult to track for everybody, including pharmacies, patients, and us. Right, does anybody want to have a break or a cup of tea or anything now, or are you happy just to carry on? Okay. So like I said, I won't go on too much about generics and brands. We all know there's a lot of switchings coming up at the moment. I think I've got a pharmacist coming in next week from the ICB who's going to go through all the changes that are happening. Are you in contact with your ICB pharmacist? Do you know what changes are happening at the moment? Because there's quite a lot, especially with the HRT medication. Yeah, go and grab a cup of tea. That's fine, Jessica. No worries. I won't go too fast. Just give me a quick shout when you're back. So are you any of you in contact with your ICB pharmacist? Do they come in and let you know if you've got a dashboard where you've got a list of what's being switched? Because patients will find, especially like I said, HRT medication is changing. Lots of things are changing at the moment, so it's worth it if you can get hold of your ICB pharmacist and just have a quick chat with them. So we've got a new guy who's coming in next Tuesday to just go through the latest dashboard so we know what to keep an eye out for. And because do you use script switch? Do you switch the medications yourself in your practices, or is it only the pharmacists who do it? It is quite good if the prescription clerks can get involved in the script switch, because it's when it gives you a chance to do some other things, it gets you to know the medication, and it's also great for the practice and the ICB because it just means the use of script switch goes up massively if everybody's involved doing it, and it just changes that medication quicker and the cost savings are there. Yeah, and it's great if you are using it, but if you don't know what switches are coming, the switches only happen, don't they, when you go in and edit, they don't automatically pop up. So like I said, if you can get hold of your ICB pharmacist and ask them what's coming, it's it will help with cost savings across the bnssg, definitely. Right, everybody, do you all use the BNF and drug tariff online, or do you use the paper copies? I must admit, I'm still old school and use the paper ones. I find it quicker. Drug tariff you probably wouldn't use much. It's more for pharmacies, really. Just because it gives the price that they're going to get for the medication they supply. But the good thing about the drug tariff, if it's not in the drug tariff, it's basically not prescribable. So it is somewhere to look, that if you're not quite sure whether an appliance or a medication is prescribable, if it's not in there, no, it's not. And the BNF is more clinical. It just gives you more brands and generics, whereas that is just basic prices and what's allowed and what you can claim for. And like we said in the last one with the BNF, it does give you the brand name and it gives you the generic name. So it's quite handy if you're not quite sure. If a patient asks for a brand and you don't know what actual medication is in the brand of that, you can always check on the BNF. It will always give you an idea. EMIS is quite good as well. Drug history, it'll tell you if you click and then go to the bottom. Drug information, it'll tell you what brands and what generics are available as well. Like I said, drug tariff really only tells you the price. So say lisinopril 20 milligrams, they give a box of 28 tablets to get 83p for it. Whether they paid 83 pence or whether they paid £1.83, that's all they'll get is that price there. So that's what the drug tariff price means. It's just the price the NHS has decided they can pay the top price. Anything if they get it under that, then on a bonus. Done that very often. Right, we're all very much in the way of being prescribed everything by generic because it's cheaper. And like I said, it's worldwide and everybody's getting the same medication. But sometimes it does have a difference in bioavailability. So how that medication is absorbed by the body, if you like. And that includes all the ADHD medication. And that's why when we're switching all this ADHD medication to generic, because we can't get brands, as soon as the brand comes back in, the patient should be put back on that brand. I think there is something, I think it might be on Remedy, that gives you the bioavailability of every brand of the ADHD medication. And it does vary quite a bit. So when patients phone up and say, I want that brand, that's the reason why. So try and switch them back if you can to the brand they should be having. So like I said, some medication should always be prescribed by brand, including epilepsy medication. Patients shouldn't switch brands. Lithium, patients shouldn't switch brands. There is a list out there. There is a list out that I have of all the medication that you should stick to a branded medication. Usually it's set up by the specialist. A lot of it is transplant medication, especially for kidney transplant patients. If they're given the oral, they should stay on the oral. They shouldn't be switched to a different one. So if any of you want that list, let me know. Just email me and I can email it across to you. Quite handy to have, because then at least if a patient rings up and says, look, the hospital told me I had to have that, and then you know why then when you see it, you're like, oh yeah. So there are quite a few of them actually. So if you want to give me an email, I'll send it over to you. And included in that list is one that's it used to be quite popular, it's not so popular now, but nifedipine. Nifedipine again is another one. Bioavailability is different in all of the nifedipines. So again, that should stay on that make. Tegretol, people should stay on that make. So like I said, there's quite an extensive list, so it's definitely worth having a look at. It's definitely worth holding on to just in case patients do ring. We had a patient the other day and she'd been switched. Lithium had gone up and she was on Priadel, and they'd given her another make, and straight away she sent us the nice guidance saying, no, this shouldn't be. And she's right, it shouldn't be. It should be on that same brand. So like I said, just send me an email and I'll send them through to you then. Right, stoma. Anybody got any experience with stoma patients? And any of you know much about it? I worked on the stoma ward for 10 years on the stoma ward on UHW. And I also worked with the community stoma nurses from Charter for 5 years. I was working for the health board in Wales doing stoma reviews. Really interesting. Really, really interesting. Yeah, somebody just said their brother. It's quite hard to manage, and like I said, it's stomach patients are usually can get easily upset because people don't understand the difficulties around stoma. It's very difficult to manage sometimes. And like I said, it all depends where the operation is done, whether it's a colostomy or ileostomy or urostomy, what side the opening comes out of. They're all difficult to manage. Colostomy can be a little bit easier, but it just depends on the patient and what's happened. Ileostomies, they tend to have more of a liquid output, tend to have to change their bags maybe 6-7 times a day. Urostomy, again, obviously, that's waterworks. That can be really hard. It's liquid. Trying to get liquid to stay in one place is difficult. So people who've had this surgery are known as ostomates or ostomists. Like I said, they don't get much help out there. So, if you can try and sort of give them as much help as you can and just understand that they get stomach upsets. So they will some months use twice as many bags if they've been ill. If they go on holiday, they get holiday stomach the same as us, and again, we'll use more bags. Sometimes the adhesive will fail, especially if the weather's hot. You'll get a batch that adhesive's not worked and they need a new one. There's not many ostomists who will stockpile their medication. The boxes they come in look like that. So unless they've got a very big house, they're not going to have many places to store it. So it is just trying to understand what they have to deal with and just trying to get their prescriptions right. Because I know in the hub, we do have problems with getting the prescriptions right. There's lots of reviews being done at the moment, especially after Southmead. So lots of things are changing. Stoma nurses are out there doing reviews because obviously they couldn't bring them into the hospitals when COVID was happening. So they're trying to catch up now. So be aware, lots of codes and lots of template sizes. We'll go talk about that are changing, and they can make a lot of difference to these patients. So it's very challenging having a stoma, and it can be quite distressing, especially if you're a really young patient as well. Relationships suffer, confidence suffers. Lots of people's life improves after a stoma. Some people's doesn't. It deteriorates, and they never really get over it. Most important thing for these patients is the template size. When you have surgery, and this is the stoma as it's created, when you have surgery, and obviously as you get older, your whole stomach, everything changes, the whole shape changes. So unless this is measured every year and checked, if it's too small, it's not going to sit around there nicely. It's just going to sort of sit halfway down, and then the patient's going to get leaks. And this is when you will see more and more bags being ordered. Patients will order tape to try and tape round the leak and try and patch it up because they think, oh, that's what happens. You get leaks. No, you don't. You shouldn't. If you've got stoma bags today are just amazing. They are so good. If you're getting more than one leak a year, the stoma nurse will tell you that's one leak too many. So if they phone you up and say, look, I'm sorry, I've got to order more bags, I've got a leak, send them straight to the stoma team. Order what they need and then say, right, you need to get a review. And I can send you over again, if you ask, I can send you over the contact details for the stoma team, and they'll put them on the list. Even if the patient's housebound, they'll go and see him. So this template, which is that piece there, needs to be measured every year, at least once a year. And even more if the patient has a baby or things like that, it needs to be checked and changed so the patient doesn't end up with leaks. So there's lots of different products, as you know. And this is the one thing where it sometimes runs away with patients. They get a leak and they don't really want to tell anybody they've got a problem. They don't really know where to go. Doctors are not really, they don't know. Hospitals, they've just sort of given up trying to get to. So they're sort of stuck. So the easiest thing to do is to go online and just order loads and loads of samples and sticky tapes and little collars and all these things. But most of it's not going to work. Like I said, it's usually down to that piece there not fitting properly. And like I said, the most suitable one depends on the patient's type of output as well. If they've got an ileostomy, a drainable bag will be better, because if they're changing 6 or 7 times a day, this sticky is very sticky. They keep pulling it off, they're going to get sore skin around their stoma. So they're better off having a one piece when it's not drainable. When it's drainable, but like I said, because if it's not, it's a constant pulling it off, pulling it off, pulling it off. Or you can have a 2-piece when it clicks off. So you put that bottom piece on first, and then that clicks onto there. If your patient is not very good at seeing or is blind, the 2-piece is the best because it clicks on and they hear it click. And if they've got sore skin, the 2-piece is good, because that base plate stays on for about a week and they just click on a new bag. So it does help their skin. So, you know, if a patient's having ongoing skin problems, again, just ask them to go and see the stoma nurse and talk about a whole change in their products if it needs to be. Some patients are on products which are like 20 years old now. They're okay, but they're not as good as they should be. So it's a 2-piece system you can get for colostomy, ileostomy, and urostomy. They can be flat, concave, convex. They can do everything that a 1-piece does. That are kindest to the skin. And you can swap it as well for, like, if you want to go swimming. You can just click on a smaller bag. The only problem with the 2-piece system, the base plate is quite rigid compared to the base plate on a 1-piece. So it can be a little bit bulkier under clothing. But like I said, it's patient's choice. If they're struggling, it's just worth a try. Yeah, and 1-piece systems do the same for all the same things, can be closed or drainable. Like I said, the only problem is they do need to be changed quite often. And that changing can cause sore skin. And if you ever get a patient with really sore skin, tell them the best thing to try is calamine lotion. It's really good on stoma skin. 1-piece systems, though, are less visible under clothing, so they do help. It's easier, they're more flexible as well. Right, accessories. Have you all got the stoma formulary, which is on Remedy? There is a formulary, and which is actually produced by the stoma team. So, you know, adhesive remover. Yes, they do need, but they don't need sprays and wipes. If they're having an adhesive remover spray, all they've got to do is, instead of getting wipes, which are quite expensive, is just spray it on one of their dry wipes and just take any residual stickiness from around the stoma with one of the dry wipes, which comes with the bags anyway. Paste and fillers. We probably don't get as many as them now because we've got convex bags, so you don't get so many pastes and fillers, but they're to fill the deep creases around stoma when patients have had the ops and they've gone a bit, you know, they have got deep creases, but they do need them, otherwise the bag is not going to lay flat. Skin barrier powders, they're something that shouldn't go on repeat. They should only be used for short term and only if the stoma nurse had advised them. So if you've got a patient asking for that and they've never had it before, It's a definite no. They need to speak to the stoma nurse before they start using those. And again, tapes and barrier rings. So the barrier rings are the little collars that fit around the template. And again, they shouldn't be issued unless you've spoken to the stoma nurse and they've actually agreed that that's what the patient needs. Because all these things online, again, like I said, they can try them, but they're not always going to work. Gauze swabs, or the dry wipes, as the patients call them, they get them free of charge with a load of black bags to dispose of all their stuff. So they shouldn't be asking for any more wipes. We shouldn't. Does anybody get any prescription requests for deodorants, or sort of like used to get the mint or the blueberry, just stoma deodorants? Ah, right, you're doing from the stoma hub, Deborah. You're right. I think that's coming to an end soon. But yeah, you shouldn't be supplying any deodorant to patients. There's no need of it. But what happens is when the patient changes the bag, that's all they can smell. So they automatically think they need a deodorant to get rid of it, but they're the only ones who can smell it because the charcoal filters in the bags are so good, they shouldn't need deodorant. So we don't supply deodorants anymore. And tape should be limited. Again, like I said, if the template is correct, 2 boxes of tape should be plenty. And that's just an added security. If they're ordering more and more tapes, you know they're trying to stop a leak, and they're not. They're just extending the leak. They're not actually stopping it. And again, barrier sprays. Shouldn't be using them regularly because, again, barrier spray, if you put a barrier up, that bag's not going to stick properly. Especially if it's, something quite like a barrier cream, it's not going to work. They can have a barrier spray or wipes, but not both. And like I said, again, that should be for a short-term thing, never for long-term. So they shouldn't have sore skin all the time, really. There's a problem if they do. So if you do need to order a prescription, what should you be checking? Because this is where it goes wrong sometimes. Every stoma product has a code, and especially with the bags, that product, the product number collates to the size as well, so it changes as the size changes. So always check that that code is correct. Because if you don't have the right code on it, you're going to get the wrong one. You're going to get the wrong size. You're going to get the wrong product. You're going to get an open bag when you wanted a closed bag. So it's quite easy on EMIS to pick the wrong one, because there could be a couple of them with a similar code. So just always make sure your codes are similar, and stop the medication if they've changed, because their size has changed. Which, like I said, they're now doing all these reviews. If it's changed, if their size has changed, well, get rid of the old one. There's less chance of you picking the wrong one again. So just make sure that, if you're not sure, if a patient's got lots of bags on there and they've not been ordered for over a year, and you can see new ones have been added, I would remove the other ones. It just makes it less difficult for people when they're ordering their prescriptions just to see the one thing that they do actually need. Right, Formio. Do any of you know much about Formio and what it does and what the hope was behind it? It just means with Formio, all the dressings are from the wound formula. So it's all overseen by nurses and the TVN nurse, which is tissue viability nurse. Stock's always available, so patient gets the right dressings as soon as possible. Whereas before, if Mr. Jones had 10 biotain and then only used one, those other 9 ended up in the bin because it had his name on there and the nurses couldn't use them again. So then the nurse would be running around trying to get another prescription for Mr. Smith, who needed exactly the same product. I've just been 9 of them. So with this now, it's the nurses have the stock. They know what their patients need. So the stock goes through all the patients then without the nurse carrying loads of people's stock about, all with different names on it. So there's no waiting for the GP to sign the prescription. They order it, they've got it there in their treatment room. Reduces the nurse's time, like I said, running around collecting dressings from different pharmacies. And it saves, it's 100% formulary, so the cost savings are there as well. The dressings are owned by the NHS and not the patients. They're not left at patients' houses. They're taken around so the nurse gets to use them all. Product uses gets, they can know what their budget is and they can manage the budget properly. And care homes can use this as well. So we found it a really good system in Cardiff, actually, and the treatment rooms and the care homes all loved it. It was much easier for them. And like I said, saves so much of the poor nurses' time. So people who can order from the Formio are district nurses, nursing home and GP practices. They've all got a different formula of what they can order. If they need something like silver dressing because the patient's got an infection or something, they can order it on there, but the tissue viability nurse will probably intercept it and get involved and ask, what's going on, has it been seen by the GP and why do you need the silver dressings and things. But it's a really good system. So do your GP practices use it and all your care homes use it? I think it's the care homes that I find dodgy. I'm not sure. We had a new lead nurse and she asked for some moisture cream and I said, is it on Formio? And she said, what's that? So I explained to her, she went on there, she said, I've been buying all this stuff off Amazon. Didn't realise Formio existed. Didn't realise that she could order all these products. And she was going through Amazon, spending the care home money when actually it was all available on the NHS for her. So it's always worth, if you've got a new care home lead, just pointing them in the right direction and saying, have you heard about Formio? Do you know how you can use it and what you can order? So level 2 is always a bit quicker. So any questions off anybody? Like I said, if you want any information, if you want any of the, like I said, the sheets about what medication should be by brand, the stoma formula, just give me a shout by email and I can send it all over to you, okay? Like I said, a bit of a shorter session on level 2. There's not so much to go through, but I hope you all enjoyed it anyway. And like I said, if you need anything, just let me know. Fill in this feedback form. Once you've filled in the forms for level 1 and level 2, you'll get your certificates for both of them. But you do need to fill in those things. I'll leave the QR code up. But if there's any problems with it, let me know and I can pass you on Millie's email address and she can then send you out the feedback forms and you'll get your certificates that way. Because my phone doesn't like QR codes. Yeah, I'll ask Millie, I'll send her an email and I'll ask her to just email the feedback forms out to everybody in the practices so they can just fill them in level 1 and 2. I'll just say you're struggling with the QR codes and can you have feedback forms? Yeah, I don't get much coverage where I am either. Right, no problem. I'll get Millie to send all those for you and hopefully you will get your certificates in the next week or so. Right, so any questions, let me know. And Judith, I'll see you soon. It's nice to see you all anyway. Thanks very much. Bye.